Good morning to the online audience and the offline audience. We had earlier done a series of talks on AI in health. We are just continuing on that series which we did earlier. This is a picture of Dr. Ida Scudder, the founder of our hospital, and she started in a one-room clinic. That one-room clinic is no longer there, but that's the picture of the one-room clinic. That's the Mary Tabor Shell Hospital, initially just a one-room clinic. Now we have a quaternary care center with more than 1,000 beds in Ranipet campus. Just to show that science progresses, life progresses, and AI also has rapidly been progressing, so that we have to keep abreast of new technologies and things that happen in life. So, if one looks at a care pathway, patients can present with various complaints which we call history, and they have physical examination done by the doctor. At the end of that, the doctor thinks of some diagnosis, and he may or may not order some lab tests which may be body fluids, images, genetics, and increasingly AI being used as a lab test. The diagnosis from these tests may be false positive, meaning it may say that you have disease X when you really don't have the disease. It may be false negative when they say that you have no disease when you actually have disease. There is a cost to every test. There is no free test, including the AI. Tests are not stress free. Patients have to line up and wait for many hours for a test. Invasive tests have pain, and the quality of life is often, if you have gone through an MRI, you may feel that your quality of life has diminished after the MRI if you are a little claustrophobic. So, the diagnosis also is part of the pathway. Then you take treatment. If the test is negative, you may not offer treatment, and that may actually be a false negative, and that will cost you if you don't take treatment. Or even if the test is a true positive, you may decide the disease is too advanced and there is no treatment to be given. Treatments come with costs. Treatments for inpatients include the wages lost or societal loss because the patient and the family member are in the hospital. So, that is an indirect cost. So, the society loses some cost, and there is intangible cost, which is the suffering of treatment. Nobody likes to have chemotherapy. Of course, you get better from cancer, but it's a horrible experience to have most chemotherapies. At the end of all of this, the patient may be better. The whole story starts with the patient coming to hospital to get better, or the patient may actually be much worse than when he came to the hospital, and he has suffered a cost, and there is a quality of life component which we must consider. So, that is a little bit about the care pathway. And when we are thinking about AI, we must, as a test to diagnose something, we may be looking, for example, like a risk factor for cancer may be smoking. So, maybe the AI can pick up that people are buying cigarettes. So, it's even before the patient came to the hospital, it is picked up that this man has purchased cigarettes. Screening is before the patient complains, you pick up a disease early. So, screening for lung cancer, for example, you do CT scans, low dose CT scans for asymptomatic patients. So, the AI can also screen patients. It may pick up disease before it really presents to anywhere. Diagnosis is when the patient appears to the hospital and says, I have got this and this, and we were trying to diagnose sepsis in our medical ward, and then the outcomes of sepsis in those medical patients, but they came to the hospital. Risk stratification is like, okay, if you have got this gene, then you will do well with this treatment, or if you have this marker, for example, in myeloma, if you have beta 2 microglobulin high, then the same myeloma patient will do worse if he has that high, and another same patient, if he has it low, will do well. So, that is also a diagnostic test. It is a stratification. Prognosis is like, okay, what are the variables which say that you will do well or you will do badly. So, AI can do prognosis as well. Response to treatment, let us say you have leukemia and you give chemotherapy, you can see the white blood cell coming down. It is a simple treatment. That is not diagnosing leukemia, just looking to see whether you have responded. Or if you treat diabetes, or the blood sugar coming down. So, the AI could help you in that part as well. Then for relapse, let us say you have prostate cancer, and you do not have to wait for the cancer to come everywhere. If you do prostate specific antigen, it can pick up relapse early. So, When you say diagnosis, people often just think when a patient presents to hospital, but actually all these are diagnoses, and the AI could be involved in any aspect of this care. So what have we done so far in our CEU? As I mentioned earlier, we have given some talks on what is AI, so that it's just, these are very basic talks meant for the beginner. But we have also done what is called STAR-D AI. So suppose you use a diagnostic test, 2x2 diagnostic test with a gold standard and a new test. The guidance for planning such a research is called STAR-D, and one of the new tests happens to be AI, that is STAR-D AI. So we had done a talk, and you can have a look at it on our YouTube channel later on if you like, on how to plan a study. Then the second one is reporting or prediction. Suppose you are planning a long-term outcome and saying like what are the factors which predict outcome. So there is a guidance document to how to predict, write a study, cohort study predicting long-term. So that's called tripod. And if you use AI to predict the future, then there's a guidance document called tripod AI. And we had talks by Mercy as well as I think Elbin, who have both done 2 talks on one talk each on tripod AI. So you can have a look at that document. And if you want to know whether the model was done well, okay, now I made a model to predict the future. Was the model diagnostics done properly? Have they developed it properly? So that is called probust. It's like both of these are like brother and sister, tripod and probust. So we have also, Phoenicia has also done a talk on using AI models to make sure the model is done properly or not done properly. So you can have a look at that. So all these are available in our YouTube channel, CU CMC Vellore. So this is what we have done so far on AI. So actually this is probably the 10th talk on AI or 11th or 12th talk. So what am I going to talk about today? This is again just basic for people. What is an LLM? What is an agent? What is an agentic system? Software as a medical device. Little bit about AI interaction and human AI interaction. AI enabled medical device. Little bit about guidance and the future. So some of us are very tech savvy and we know everything about AI. Other people, AI is just like, instead of Google, I'll use ChatGPT. So most people in the world are now, instead of Google anymore, they use ChatGPT or Claude or DeepSeek or whatever your favorite AI devices. So we have different levels of awareness. So I'm going to just first tell what is an LLM, what is an agent, an agentic system, and then software as a medical device. So this is a nice article which came out recently in May 2025 in NEJM AI, the typology of different AIs, because everybody imagines things to be different. So if you're already an advanced AI person, this will be very basic. So the first thing is, what is an LLM? Like for example, ChatGPT. I think everybody in the world knows, even children know ChatGPT now. It's a computer program, and you give it a lot of text, it learns from the text, and basically it tries to give you answers. So the text is to predict the next word, how are, and you obviously know you may be the next word. So it is not that it's an intelligent system, but it just predicts from the huge amount of text it has got earlier. If somebody says how are, the next word is most likely to be you. So that's the main part of what large language models do. You can also use it to translate different languages. So it converts the language to a computer code and then back to language. So that some people call it as vibe coding, just because to know that. And of course I made it sound like LLMs only are used in language, but you can use it beyond language. So those are called foundational models. It can be used in healthcare as well. The only important thing in healthcare is, of course, we type a lot of text: history, physical, diagnosis, differential diagnosis, discussion, recommendations are all text. So LLMs are very good in predicting the next text that you want to use. But we also have in medicine images, audio, recurrent data, like some of the ECG is recurrently done, or a continuous glucose monitor. So there are different types of data. So that's a bit of a challenge for an LLM, because the data is of various types, and predicting the next part of data becomes a little bit tough. LLMs are also various types. The most common are called standalone. Standalone LLM means you have given it a huge amount of training data, it learns something, now it can tell you the next word or whatever. When you start typing, it will tell you this is what is likely to happen. You ask a question, it will give you the answer based on what it has learned from the prior information. But the only important thing is it doesn't have any new information. It can't learn anything other than what you have fed it. So, it is totally reliant on what you trained it. Secondly, like if it has told you an answer earlier, it doesn't learn from its previous experiences. Like, oh, you were wrong, you were right. It has no memory to learn from previous experience. It's largely dependent on the prompt. So, the kind of question you ask is also called the prompt. So, very often in medicine now they say you must tell the, if you are going to report a journal article and you use AI, they will ask you please say the prompt, meaning what question did you ask the AI, what version of AI did you use, and in which part did you use for the introduction, methods, results, discussion, analysis, where did you use it. So, you must learn to be able to say a bit about that. And the other thing is it can't act on its responses, meaning if the AI tells you, you must do this course of action, you must start aspirin, it can't see whether you actually started aspirin or not. The AI, the LLM will just say, I think you should start aspirin. Whether you did or not is not part of the LLM. So, the second part is AI agents. Now, these are slightly extended LLMs in a way. So, it acts autonomously. So, it can do what it is recommended. It has got another loop where it can implement what it is recommending. So, got a loop to see whether if what it has done is being done, and then it can feed back to itself, yeah, I did it well, and whatever I recommended worked out well or didn't work out well. So, I will give some examples in the subsequent slide, but just to say that AI agent is slightly more advanced features. It can do something, check if it can recommend something, check if what it was recommended was done, and then give a feedback and see if what happened was good. Then we go to agentic systems. This is like many AI agents talking to each other. So, this is a whole system of AI agents. So, they must act together synchronously to accomplish healthcare. So, obviously, to orchestrate that all these AI agents are working together, you need to have a manager or orchestrator, somebody who makes sure that all these agents are working together. Let us have a look at these. First is just an LLM. This is a hypertension textbook by Braunwald, and this is a review article of literature which we often are supposed to write as students, write a review of literature. So, LLMs are either like a textbook or literature review. You just feed lot of information into it and then you ask a question. I have a patient with hypertension on 2 drugs, what to do? So, then it will give you an option, okay, there are one more drug option available, and it may also say that please do this test for secondary hypertension workup, right. So, that is what it can do based on the knowledge it has been fed, it just feeds out an output. So, this is the basic kind of work that an LLM does. It cannot see whether, okay, Reba, you typed secondary hypertension, did you actually order the test or not? It stops with whatever it has done. Next time you search an LLM, it won't remember this is what information I gave last time. Next we come to AI agents. So, now it is like, okay, in the OPD I am sitting there, blood pressure is not controlled, I have an AI agent. The AI agent automatically prescribes this patient already on 2 drugs. Now, it will prescribe the 3rd drug, and it will check whether the person's blood pressure was checked later on, and it can schedule an appointment for the guy 2 weeks later. It can also order the blood test for secondary hypertension. So, this is a slightly more advanced version. So, this is called AI agent. Now, the agentic system is slightly different, okay, slightly more advanced than that. A patient comes into the OPD with smoking, hey, it can predict your risk of cancer is high. Then it can schedule, you will have a low dose CT scan to see whether you have got cancer already, it is screening you for cancer. Then it can prescribe a nicotine patch for you, or it can prescribe counseling for you. And then say who going to pay for all this, it will even write to the insurance company and see that you are paid for all these things together. So, it can do all these things at one shot. So, this is called a agentic system. Now, just to make a little bit of a joke, many years ago smoking was considered a good thing. Even when I was in college, most of the faculty used to smoke because nobody thought very bad of it. So, this is called the robot smoker. So the man is really sick because he's been smoking a lot and lying down breathless, but he's got a device attached to a small tube, and then he lights a cigarette here. All he has to do is just breathe in and breathe out, so he doesn't have to hold the cigarette. He can keep reading his newspaper, lying down in bed, wheezing, at the same time smoking, and they call it a robot smoker. So the idea of AI and robot has got different connotations for different people. Now another one, this is agentic system. This is a larger agentic AI system. This is, for example, Vellore district, and I just googled and found that we have got a district health officer, district fire officer. Suppose the district health officer says, you know what, couple of weeks ago we heard that, what is that cohort study we read on hypertension causing heart failure? Pure AI study, and then the pure study found that uncontrolled hypertension is a big bane in India. People are getting huge amounts of heart failure. Let me control hypertension in Vellore district. So he gets an agentic AI system, and he says across Vellore district you are supposed to control blood pressure. So it independently accesses all hospitals in Vellore or all clinics in Vellore, assuming they all have electronic medical records. It captures everybody with more than 140/90 blood pressure. Then it gives them a clinician's appointment, or if they can't get clinician appointment, it automatically prescribes medicines for them. It gets tests for them. It schedules appointment dates. It tells the patient, you know, please go for this human being, see this human being, and it keeps repeating the cycle and keeps checking the blood pressure at the population level of Vellore district till most hypertensives in Vellore, or let's say it has a target, at least 80% of people with hypertension in Vellore district have to have a BP control less than 140/90. So it's much more, it's a much larger system. So this is also possible. So this is an agentic AI system. So it's available in many places, and it sounds like science fiction to me, but it is reality in many places. So what are the implications for this? First is, do we trust what it says? Very often we blindly trust. Okay, we make academic presentation, please tell me hypertension secondary causes, and it makes a presentation. And we just blindly trust that whatever it says is true and useful. So clinicians do use it. Patients are increasingly coming and saying, doctor, I have fever and cough. ChatGPT says I may be having dengue or I have TB, can you please check? So they trust whatever it is. Policy makers also are using it. Now the problem is that if the patient uses ChatGPT and ChatGPT has searched Wikipedia, the source of information for ChatGPT may not be reliable. So we have to be a bit careful about that. Many of the doctors, healthcare workers are using it to do literature reviews. But is it an accurate source? Has it hallucinated half the information? We don't know that. But the argument is that there is so much of literature, I cannot possibly spend my 3 months doing literature survey. So I am just going to do it using an AI. Now healthcare organizations, suppose CMC, all the doctors are, okay, this X-ray is here, I'll take a photo, upload it to X-ray AI, it will give me an interpretation. Is that accurate? Are we making a mistake? Are we making errors in our hospital system? So there are different levels of trust that is very important that this AI needs to cross. Now constraining means you tell people don't do. You may not do this, you may not do that. Regulating is you may do it under circumstances. We are giving you permission to do, but do it carefully. So there are two ways of handling AI in healthcare. One is they say you may not use it. The second way is, more smarter way, is regulate its use. So it's like a textbook or a journal. When you submit to a journal, it is peer reviewed and then it is published. So somebody is checking what is going into the journal. It's not just published immediately. Now everybody likes freedom of information. Suppose I tell you, you cannot use ChatGPT. You will say, who are you to tell me I can't use ChatGPT? I will use it. So we all like to know what to do. So who is regulating what is coming out of ChatGPT or Claude or whatever? Market. If ChatGPT is giving wrong answers, people will stop using ChatGPT. They will go to somebody else. So the market is sort of regulating what's going on. The only exceptions for large language models during COVID especially, apologies to psychiatrists, many people were highly stressed out. They could not go to a psychiatrist. So there are online single use LLM psychiatrists. You could just Google online psychiatrist. It will give a name. My name is so and so, A, B or C, and you can talk to it like a human being and say, yes, I think you are depressed and you must take this medicine, or you need to have this counseling, or you must do some exercise. And with a single use LLM which will appear to be like a human being, of course you know you are talking to an LLM, but you can sue that LLM now. So that's the only place where people are becoming a little bit careful if you have behavioral LLMs, which is this, and you need to be a bit careful about these behavioral LLMs. So people can, and then there's a policy like what happens if the LLM gave wrong information and the patient did something to themselves, then what to do. So there is a different amount of AI literacy that people have and your confidence, and then the task at hand may be critical, it may not be critical. So actually talking to somebody who's got a high suicide risk is a critical information, and the AI and the person who's talking to the AI may not be very literate and may not be competent to understand what the AI is saying is correct or wrong. So that's something important to keep in mind. Next one concept which I want to move on to is called software as or in a medical device. So this is again, it sounds like a mouthful, but it's something that we need to know. So AI can take actions based on the information it has, and the more the risk of the AI, the greater the benefit. So if you have an agentic agent which is controlling blood pressure in your whole district, you don't need many people to do it. It sounds like, hey, if it gets it wrong, it's a big problem, but if it gets it right, it's a huge benefit. So the increasing risk of AI, increasing benefit. So now the Food and Drug Administration in the US has classified many of these AI as software as a medical device, and it needs FDA regulation. So what does it say? Are you going to use this device for this AI for patients? Yes, that's a very important thing. Is it a software? Yes, all these AI are software. So then it comes as a software as a medical device. Hardware is basically the computer and the RAM and ROM and all those kind of things. So if the software is a medical device and you're also talking about the hardware required, the marriage of all three of these is called software in a medical device. Otherwise, just an AI and the software is called software as a medical device. So just to know that when people talk of SAMDs and have you got regulatory clearance, what is this strange thing? Almost all the AI in healthcare now require clearance. So just to say that this sounds a bit, to me, there is a healthcare system called amorphous health, like CMC Health or Apollo Health. In the US, there's a healthcare system called amorphous health, and they use AI for automating clinician work. Why should we write progress notes? We talk to the patient, it captures the discussion and it writes progress notes. Why should you write history and history? I talk to the patient, I listen to the patient, it captured the history. I can write few lines of discussion, it will fill it up for you. Decision making, based on that the AI will order tests for you. Based on that it will order medication for you, and it's personalized. It won't just give all patients the same thing. You will get different care, and 24/7 it's available. It can even help with billing of the patient, follow up of the patient. So this kind of thing is agentic AI. So it can be trained in diverse tasks. Now the thing is, if you remember this LLM which I told you earlier, device, software as a medical device, you can, okay, this is a device to control hypertension. So you can check it out and see if it's good or not, and then give permission to use. FDA can give. But how does FDA give permission to an agentic system? Because the agentic system is learning constantly. Hey, I did this and the blood pressure didn't come down. Okay, I must change my strategy and do something else. So the agentic system is constantly evolving itself. So how do you give one-time permission for this agentic system to be used? So regulation of agentic systems is more complex, and we need to be a bit more careful about it. So what all, again, just to say, it can do symptom triage. That means in the casualty it can look at symptoms and say, you are a sick person, you need emergency care. You are not so sick, you can go to level 3 in the emergency department. It can help you with documentation. So increasingly in many hospitals, the doctor just looks at the patient, has a nice happy conversation. The AI in the background is listening to everything, and it makes a summary note and puts it up as the history. Patient gets a copy which is he can understand, and the doctor's a little more technical information automatically is fed into the system. Documentation, administrative tasks. So like, okay, there are too many patients in this queue, let us automatically open another counter somewhere else. This is what's happening here. The AI can automate those kind of processes. Medical compliance with medication, we can see, okay, has Reba really bought the medication? Of course, we can't see whether she's actually taken it, but Reba's blood pressure is not coming down, at her home blood pressure is showing at high blood pressure, maybe she is not compliant. she can check with that. Post-surgical care, has the wound been dressed on the 3rd day, has X and Y been done, have all the drapes been, all the things been removed, and revenue. So, the hidden thing is that AI can optimize revenue. So, I will talk about that in a little. So, this joint commission is a commission which is responsible for the quality of health care. It has brought out something called Commission and Coalition for AI Health, CHAI, and it made a framework called AI in Healthcare Framework 2025. It took into account clinicians, IT people, legal people and patients' perspective and made a sort of framework for the use of AI in healthcare. It also does something called bias audits. We have used this example many times. In some places it will say AI is responsible to control blood pressure in Vellore district. So, the AI thinks, okay, I must be cost effective. If I can spend less money and control blood pressure, great. Now, there are some parts of Vellore which are very poor. Poor people live in some parts. They don't even know they have hypertension. They can't afford the medicine. So, their compliance is poor. So, will the AI give more money initially to that area or less money? It will give less money because, hey, if we invest money in that area anyway, nobody will take the medicine, and therefore, it will direct money more towards richer areas of Vellore, which people are more educated, they are aware of health care, they will take blood pressure medicine. So, the AI will be a win-win for the person because you are spending less money. Overall, Vellore district's blood pressure has come down, but the poorest of poor who really need it may not get it. So, these are called biases within an AI. Unless you are careful, human biases will be reflected in the AI. So, it's very important that these biases are, and nobody will know. Because there is no human being making, you can't blame the district health officer, you didn't give enough blood pressure medicine to this part of Vellore. The AI made the decision. Those people don't even know that they didn't get medicine because they didn't know they were part of such a program in the first place. So, that's something to keep in mind. So, this is called the responsible use of AI in healthcare. Of course, everybody likes abbreviation RUAIH. So, what are the policies and governance structures for AI? Patient privacy and transparency. Suppose you take a patient's X-ray and you put it into take a photo and upload on the net. Is there AI privacy? Is there privacy in that? Automatically it goes to some AI, to some cloud server somewhere. Patient's privacy is already gone. Data security and data use protections, ongoing quality monitoring. Hey, we started this AI system. Has it really been doing well? What if the AI made a mistake? So, now we have in our hospital near miss reporting. Yes, a mistake was happened. I mean, we made a mistake, but the patient didn't suffer as a risk, as a consequence. But we better learn from it because if we don't learn, next time the patient will suffer. So, we can have like that near miss reporting in AI, and then education and training. So, looking forward, we need to be very aware of LLM is different from agentic system, and as the benefits increase, so do the risks also increase. So, we must also think, is AI in healthcare, is it a clinical versus non-clinical? What is the level of risk to patient and what is the existing regulatory authority? So, CMC itself has brought out a draft AI policy for different uses, and I think that people are debating those various issues. Now, I told you there is something called agent to agent interaction. Let us assume Vignesh is a patient and now he is smart, he has got an AI agent for himself, his own healthcare data is in his own AI agent. Let us say Reba is the healthcare provider and she has got the hospital's AI system, and let us say that Georgie is the pharma person, he has got his own agent, AI agent. Namrata is the insurance person. So, like this, all these, sorry I put patient twice, everybody's agents have to talk to each other, because everybody is now increasingly using AI. So, we have to talk to each other for administrative matters. How does the patient come, where does he get his test, how does he get medicines, how does he follow up, and clinical care, where does he go, does he get his appointments. So, we need to be engaged with these. We should not say that, status quo, forget it, this is all very complicated, let us not have an AI governance system. We have to have, because systems are changing very rapidly, everybody is using AI. So, there is no option but to have some sort of a governance model, not to constrain it, but to keep it under check, to make sure that it is not running away and making mistakes for patients. So, we need to keep pace with what is happening. So, now a little hidden part, I told you about money, AI increases income. So, this is a nice report called Pay Up or Payday, it's a stat report. So, the hidden problem with AI was supposed to reduce cost, computers were supposed to reduce human work, give us more free time for family and leisure. But actually if you look at it, nobody's free time and leisure came down, actually everybody's work hours increased. There is no distinction between home and work, because you take your computers home and you continue to work. So, people thought that, if I have AI in the OPD, I am going to just talk to the patient, don't need to type anything, automatically the AI takes history and physical. I can just write AI, this is what happened to the patient, it will write a progress note so everything should be good, and it should save money, because human beings' time is money. But what actually happened is that the AI said, let's see, the registrar is now also giving advice, don't smoke, please exercise, stop chewing pan and tobacco. That is lifestyle advice. So, now we never charge for lifestyle advice. Lifestyle is a separate component of healthcare. So, let us build the patient for lifestyle. Previously, it is just part of a healthcare practice, you must give preventive health advice, exercise. But now it has decided, hey, there is a billing heading called lifestyle advice. So, it will start billing the patient for that. Why? Because the AI's job is also to increase your profits. So, suddenly it found that actually now all people who use AI in healthcare, their patient's costs have actually gone up, because the patient has to bear the cost of all this tech plus all the extra thing which AI has found out. So, increasingly in India also, insurance only pays for everything. So, now insurance is fighting back. Hello, show us that part where lifestyle was given. Why should we pay? Because ultimately the insurance person is paying back. He doesn't want to pay because his profit is coming down. So, you can see this new strange kind of dynamic is evolving between the AI agent and the insurance agent and the human being behind AI in healthcare and the human being behind AI in insurance companies. So, even to check for errors, we are using AI. Whether AI is making an error, we use AI to check if AI is making an error. So, this is a framework for human AI interaction in medicine, and I am going to spend some time on this one. So, just bear with me as we go through time. So, if we look at this interaction, accuracy means, let us say Namrata saw a patient and she accurately made a diagnosis. Yes, this person has lung cancer. So, accuracy is here. Here on this spectrum of the x axis, AI is more accurate than human. So, I am just making a joke, this AI could diagnose lung cancer better than you. Here on this end of the spectrum, Namrata can make a diagnosis accurately than a AI. On the y axis is called complementarity. Now, we say that opposites attract, the husband is a very chill out guy and the wife is type A, or the husband is type A and the wife is chill person, and that opposite attract, but that is not the complementarity here. If Namrata and the AI both make the same mistakes, is it good? So, that is what is called same errors. That means neither of you will pick up your mistakes, but high complementarity is actually different errors. You will make one error, AI will make a different error. So, let us start with here where Namrata is better than the AI. This is called human dominant quadrangle, and if both of you make the same errors, we will follow only Namrata's opinion, because AI is not adding anything. Okay, in the same human dominant part, where the AI is making different errors, it may flag up Namrata's error, Namrata may flag up AI error. Still, because Namrata's accuracy is better, we will go what the human being says. Let us say Nishi is not so good at diagnosing some rare genetic condition. I am just making fun, Nishi. So, the AI is slightly more accurate than you in judging this. So, it is called the AI dominant part. Now, if both of you are making the same errors, you are not able to pick up errors in the genetic diagnosis, neither the AI, we will just go with whatever the AI says. However, If you are making a different error, the AI is making a different error, then that's still AI dominant, but the human being is supposed to review the AI's output. So, the AI is much more smarter than me, but since it's making different errors to me, I initially must review what the AI has said. In between is the hybrid area where both AI and human beings, for many things now, for example, radiology images, the AI is as good as a resident, it may not be as good as a senior radiologist. So, it's somewhere, if you compare it with a trainee, it may be just as good. So, then this is the hybrid area where if you're equal accuracy and you're both making the same mistakes, then you must have some sort of methodology of resolving disputes. The AI says, I think this is TB, and the resident says it's not TB. Both are about equally accurate, both are calling the same thing. What to do now? On the other hand, if they're making different, again a hybrid review, which part the human checks, which part the AI checks, so sort of mutual checking on each other. So, this is a sort of a nice format to think about human AI interactions. The previous slide I told you about AI interactions. Now, we must increasingly start thinking about human beings and AI, how we interact in clinical care. So, this framework I found very useful. So, next thing, everybody likes to talk about this thing called the tip of the iceberg. It's based on this article which is published again in the NEJM AI. So, what is AI and what is not AI? So, what is the tip of the iceberg? Now, for example, the hospital decides that chest X-rays will be read by AI. So, it is integrated with our chips or electronic medical record. We have purchased the AI system from, let us say, I am just giving an example, Cure AI, and it was a part of our research project. Then it was reviewed by the administrative committee and every committee, and finally they said, yes, these are the places in which we will use chest X-ray for AI. Now, do all clinicians use AI tools? Let us ask the residents. Have you ever used AI for differential diagnosis, for reading, for writing? Yes, we are all using it. Have we put text and asked, give something? These are the history and physical, please give differential diagnosis. Yes, many of us have used that. We have given prompts. Now, the problem with this up part is the visible governed AI. This lower part, which is actually most of what everywhere in the world, I am making fun of us, but everywhere in the world, most doctors and healthcare providers are using it. It is less visible and it's quite pervasive. Everybody is using it. So, there are two kinds of responses you should not use. Clinicians should not use AI to make differential diagnosis. Clinicians will continue to use. They will just stop telling the admin that I am using it. So, the preferred path is some sort of auditable use. Yes, guys, you can use AI to write the differential diagnosis, to write your progress notes or the discussion, but you must say it has been used and somebody needs to check every time when you have used AI. Right. So, that is an important way to say that instead of saying you will not use, then everybody will use and then it not at all audited. It is better to allow people to use, but you have a code of conduct where you can use, where you should not use. And so, I would suggest to everybody slow down a bit when you are using AI in healthcare. Think a little bit, in that 4 quadrants, where are we in the AI human interaction. So, for example, now in medicine too, we were looking at sepsis. AI, can it predict the outcome of sepsis? And we found a model that was quite good, but that was based on retrospective data. Now we are trying to do a prospective verification that that AI model actually worked. Let us say that that AI model actually works. Then how are we going to implement that? As soon as the patient comes to the emergency department, all the data must be entered into the AI, and as part of the workflow, the resident or the intern must be able to see that, hey, the AI has predicted that this guy is likely to become very sick, and then what should he do? Hey, you are anyway going to die, go home, or you are very sick, you better go to ICU. What should we do next? So, that AI should be integrated into the routine workflow. So, all those things are quite a difficult process, and then who is going to govern if that is really doing well or not? So, that is why we need a governance structure. We can't, otherwise you know what happens, everybody and his uncle is making AI models, but it is never getting into practical use, because ultimately it has to be practical use, which will be part of our workflow in hospital. That is why I gave the first slide on the workflow of a patient coming in. Somewhere into that AI has to be integrated, then only it's actually useful. So just to say the same phases, retrospective evaluation is what Dr. Vignesh has done, a large study of 1,800 patients with sepsis, and our model was able to predict outcomes very successfully. Now we are not telling, we have gone to the ethics committee, but we are doing a not so silent, but we are evaluating it. The next step is what Tina has been teaching us, implementation. How do we implement this model in the actual hospital? Governance, the hospital is quietly looking at us, hey, you guys are developing a model, let's see what's happening. And then after some time they'll ask, Dr. Vignesh, did it really make a difference to patients? Finally, they'll hand it over to the CHIPS department, which is our hospital's IT system, and ask like, okay, CHIPS will say, sir, we actually have 20 IT projects, so many AI projects, each department is giving an AI model. How do we prioritize it? To implement Dr. Vignesh's sepsis model is going to cost so much money. How do we integrate it inside our existing EMR? And then we need to technically see that it's really working or not. Finally, we see change management. Yes, before we implemented this sepsis AI, what happened to the outcome of patient with sepsis? And then now after implementing it, what are the difficulties we faced and how well did it do or not? So these are the governance pathways that needs to be established. So this is a joke. I don't know if you can recognize who this cartoon character is. Anybody? Homer Simpson. Homer Simpson. And that is him sleeping well. And this is now he has become a AI governance pro. So he is thinking of all sorts of rules and regulations that need to be done. So people who govern AI have to actually be awake at night thinking, what am I doing? Like, for example, this is not a nice example to say, the current war in Gaza, did the Israeli government actually decide where the terrorists or, depending on your view, are they terrorists or freedom fighters? How did they know where they were and how to bomb them? They just told the Anthropic AI, just tell us most likely where the terrorist is. And it decided who's a ordinary family member and who's a terrorist, and the AI system bombed those people. So it has got some consequences. It's not so harmless, and its reality can be quite different from what we think. The next one is generative AI. We think of, can AI make paintings? Can AI generate music? Which never existed before. It's not like, one of these girls that are painting, copy the same painting. No, make a painting which looks like Kerala old king style painting on this. It can do anything. It can make music based on Ilayaraja style, on A.R. Rahman style, music combining A.R. Rahman and Ilayaraja style. It can do anything. That's called generative AI. Predictive AI is what we have been doing so far, predict the outcome of sepsis. So this is a common thing saying fitting a round peg in a square hole, meaning what you're trying to do is not exactly fitting into what you need to do. So which is more difficult, you think, to regulate? Generative AI. But most of our regulations are built around predictive AI. So this whole slide is about talking about that when we try to make increasingly we are using generative AI, and then we are trying to squeeze it into a model which is built or a governance structure meant for predictive AI. So we need to be very careful about this, like our model, our governance structure should fit into the model that we are using it. Are we using an LLM, agentic AI, agentic system? Is there a component of generative AI? Will we be able to govern that generative AI? So there are issues regarding ethical concerns, regulatory framework, transparency, accountability, fairness. So what happens when things go wrong? Who is responsible for it? So suppose you use AI, who's responsible for the use, having used that AI? The doctor is responsible. So somebody has to own up, yes, I used the AI, but if you use, and somebody will say, no, the AI made a mistake. So who takes ethical responsibility for having used that AI when things go wrong? When things go right, everybody is very happy. When things go wrong, who takes responsibility for that? And if we don't tell people that, we are using a generative AI model, generative AI is creating new content. It may not be exactly what the patient says. So we use generative AI in our hospital, but our governance structure is meant for prognostic AI or just a simple LLM. That's all we can govern. Who's responsible when the generative AI makes a mistake? So we must be a bit careful. So just a last joke. What will be the impact of ChatGPT on our business? There's lots of don't knows for sure, like how much of it says is made up. or if it will take away our jobs, or the security risk, or if it could damage our reputation. What do we know for sure? That we want to adopt it as fast as we can. So I think we are all in this phase now. Hey, the next hospital in the next district has already implemented AI. So we look like idiots if we don't implement AI quickly. So we are in a great hurry now to implement AI. Not we means everybody in the world is trying to outpace each other. You have got ChatGPT 4, I have got ChatGPT 5. You have Claude version this, I have Claude version that. You have agentic AI, I have agentic system. So we must be very careful about that. So when I made this slide, and now it looks a bit foolish. These are things which many people use actually. Doximity, GPT, Open Evidence. UpToDate is a commonly used software. I don't know if you use it in pediatrics. You guys use UpToDate often?
Very often I
refer to it. Now they are coming up with UpToDate AI. You can search within UpToDate and it will tell you what all to do. Like general tools like ChatGPT, Claude. So it could be medical knowledge databases. It could be general tools. So from a physician's perspective, these are high risk. What will happen is the physician becomes reliant on this. Even when UpToDate came, many people thought that people will stop reading textbooks, will start looking at literature, opening PubMed, looking for articles, because now whatever UpToDate says we will blindly follow. UpToDate is written by a human being and they will have their own biases and mistakes. So we may all start practicing medicine which is not relevant to India. So there are all, and now if you have AI on top of that, it may only increase the risk. The other thing is it takes time for all these tools to mature. Mature meaning, hey, the first model, let us say the Tesla car. The first model was called Tesla Roadster, which was falling apart. It had huge panel gaps. It took about 10 years before Tesla made a beautiful car, which is now the highest selling EV car in the world. But it took time for that to mature. Similarly, for AI in healthcare, I have got a new model. Just be careful. It will take about some time before it becomes good and it's stable and everybody understands its plus and minus. That's called time to maturity. So let me just show you what I'm saying is not made up. If you Google this website, US FDA, and put artificial intelligence enabled devices, you will come up with a list of devices. This is the website and it says artificial intelligence device. And I was looking for sepsis because in our we have tried to make a sepsis score. Actually, there is already one thing called sepsis immunoscore, which is AI as a medical device. And this is the number given to it. It is submission, and it can see this. Now, this is from the FDA page. It is a de novo number, the device number. Who is the person behind this device? When it was received, the application for the device and the decision date, and it was granted or not granted under a general hospital and any other subgroups, gastro, urology, and the type, it's a direct kind of a device. Then it gives little bit about the regulation number, the risks, the product, and the sponsor of this device. Then it says for this sepsis score, what all data will the AI collect automatically from the electronic medical report. So they are like blood pressure, age, white cell count, sodium, potassium, albumin, CRP, lactate, which is quite similar to what Dr. Vignesh has done. Finally, it will get an output, a sepsis risk score 0 to 100, and it will tell you are you low, medium, high or very high risk of having sepsis, and it's given the scores like low, medium, high, the interpretation and the range of scores. Then it will tell you the likely outcome for those people and the workflow, meaning where is this score supposed to be integrated into your hospital? Is it casualty? Is it medical ward? Is it ICU? How do you integrate it into your electronic medical record? How it is workflowed? So that's what I'm trying to say, that this is already there, and there are so many. If you look at this website, AI enabled medical devices, there are a huge number of them already there, and there are more than 50 pages of these devices already approved. So this is reality, and these regulations have already come through. I'm just trying to. So the last part of my talk, last few minutes, artificial intelligence enabled medical devices, what I just showed you earlier. There are cognitive risks, meaning thinking risks, and systemic risks associated, and there is a possibility of impaired human. So, cognitive risk is our human decision making is either degraded, distorted or manipulated. It is a thinking process error. That is what is called cognitive biases. It can affect human beings as well as organizations. So, the human related factors are like misinterpretation. The AI said this, but I understood it slightly differently. Mistrust, miscalibration. The AI said, I am not very sure, but we did not see that part, we just blindly followed whatever the AI said. AI said this guy has got malaria, let me treat. Third, automation bias. If I put it in here, I will get some result, I do not need to see whether what I got is right or wrong. De-skilling. After some time we forgot how to read a malarial smear. Why? All malarial smears are automatically read by computer based AI. It takes a photograph, it reads it, nobody knows how to read a malarial smear. Techno stress. On top of having EMR, typing EMR, now you have to integrate with AI and talk to AI. It may increase your stress, it may decrease your stress. That is called techno stress. Workplace friction. George is very good in AI, he knows how to interact. I don't know much about AI. Now we start fighting because he's like, hey, this man is so slow, he doesn't understand what I'm doing. Indication creep. ChatGPT will tell you clearly, I am not a doctor. You see, many of these online TV shows, Oprah or other people like that, they'll give medical advice. For the last slide, they'll say, we are not medical professional. This is just a general opinion. Techno creep is first you use ChatGPT like Google. Soon you put patient has fever, cough, he is from North Karnataka, some monkey died. Oh, it comes as Casnur forest disease. Then you say, yes, now I believe ChatGPT has given the right. ChatGPT is not meant to be a doctor, different. Then you say, what is the treatment for? You ask ChatGPT treatment. That's called indication creep. It is not meant as to replace a doctor. It is okay for a patient to understand his symptoms. It is not meant to replace your thinking as a doctor. That's called indication creep. Change and mode mismatch, meaning we all know that when, for example, we have SPSS, or let's not use SPSS, if you have EndNote as a reference manager and a new version comes out, the old version won't work. So, the new version came. So, when an AI version upgrades, suddenly you will find that the doctors are used to the old version and they are not comfortable with the new version. Mode mismatch is some changes happen and you are not able to understand what changes happen on a daily basis. Some of these things are like simple, like if you have a software glitch, sometimes the computer doesn't work, you call up the IT guy, you say just shut off the system, and it's some sort of a bug. The bug will correct itself if you just restart the system, reboot the system. So, some things could be just simple as that, or it could be a major change in the way the AI is used. So, when you have guidance, and I am going to go into 7 of these guidance documents, first is you must tell who is the AI for, what is the use, and who are the users, and whom it should not be used for. The guidance must be based on the trust, comprehension and safe use. That is a major principle. The guidance document must say where is the workflow. What training do the doctors or healthcare workers need before this AI is used? Anybody know what is a safe backup? If your laptop crashes, have you backed up all your information somewhere else? So, most of us will email it to various email accounts as a backup, or have a Dropbox or somewhere else very safe. What is a degraded or offline path? Degraded path actually is that the AI will still work, it won't work as well. Again, I am using the example of an AI car. When the battery is less than 10%, it doesn't stop. It goes into a degraded mode. The car will automatically go down to 10 kilometers an hour, AC won't work, many of the music system will stop, but the car will take you safely to the end, or at least till you can pull over to the side. So, the AI often now has got what is called both an offline backup or a degraded path, where the AI will not just suddenly stop, because now we are all dependent on the AI. It should have a degraded path where before it shuts off completely, it goes into a limp mode where you can do some functions before it stops. Finally, how do we evaluate and monitor it and communicate updates? Hey, the new model of AI has come. Now the doctors need to be either trained or told. For example, when there's a tragic crash of the Boeing plane, I don't know if you remember, Indonesia, Ethiopian Airlines, they upgraded some software and they decided not to tell the pilots about it because they thought it's an AI based system and they need not know about it. And in both instances, the plane took off, something went wrong, and the pilots did not know that the AI or the system in the background was forcing the plane to land for some reason, and the plane crashed and everybody died. So we need to be aware of upgrades, and we can't never accept this is in the background, you need not understand it, never fall for that. And we can, so these are the biases possible, and when you make a document in AI, it must tell which of these biases is referred to in which of these guidance document. So human beings can misperceive, misinterpret or mishandle information, and we need to be aware of this, that when we interact with AI, we have our own biases and we also will add to the bias of the AI. So this is called human factor engineering. How to identify what are the places where human beings will misinterpret AI, and how to make sure that we categorize, make sure that this human AI interaction will have less problem, right? That's called human factor interpret. So misperception. Does anybody know the Bay of Pigs story? Bay of Pigs is in Cuba. So the Soviets had some missiles there, and this is the United States, and the Americans were very convinced that nuclear weapons are there and they are going to target the Americans. So the President Kennedy at that time, when he asked the CIA, they said we have a fair chance of success. Kennedy, but the military parlance, fair chance is 3:1 against. Means there's only a 1/4 chance we will succeed, 3/4 chance we will fail. So when we communicate something, it's easy to misperception or misinterpret the information. So what the AI says and what we understand should be the same. So the first major problem is misperception and misinterpretation. For example, why did you stick out your tongue? Suppose I stick my tongue out one of the girls and they may say, how rude you are. No, I was just licking, earlier we used to lick stamps and stick it. So second, amplification. So sometimes we may amplify the misunderstanding. Hey, the AI said that it's probably Casnor forest disease, but we didn't read the word probably, and we informed the district health officer we have outbreak of Casnor forest disease in Vellore. So sometimes these misinterpretations can be terrific. Trust miscalibration. We have to be very careful not to over trust an AI output. Always I should say that this was read by an AI, it is not a human being. Don't implicitly trust whatever the AI says. Sometimes these are unintentional. Basically, we blindly accept whatever the AI says. Automation bias. I have already talked about this. So we are already very busy and the AI can do half the task for us. AI, please write the discussion. Done. So we are biased because we don't want to write that, we have too much workload and it's easy for us. But that boundary between where we should stop and the AI should start, or where AI should end and we should start, is not clear. De-skilling, I already told you about, that after some time we will not be able to do a task if AI is only doing it. It happens in medicine. Once you open a HIV clinic, all the patients go to the clinic. Then the general physician who was managing HIV can't manage HIV anymore because it's a long time since he managed the HIV patient, because all of them are going to the HIV clinic. So you become de-skilled. This is very important, especially like you don't know how to read a malarial smear anymore. You depend on the AI and the AI starts making mistakes. Neither you nor anybody in your system knows how to identify that the AI is making mistakes, because you don't have the skill anymore. If you are still skilled, you can check once in a while and see, is the AI doing right or wrong. So it's very important, especially if you are governing somebody and you are doing an AI and you introduce AI completely, somebody must be there to make sure that the AI is doing right or wrong. They should not be de-skilled. So that's just the thing, be careful about completely relying on AI without having somebody who knows whether the AI is doing right or wrong. Techno stress. I have talked about techno stress already. So, if you don't know where the AI starts, friction will start in your. So, for example, handovers. Very often in the ICU setting, emergency, we have handovers. So, will the AI do the handover? I have written AI based notes. Will the next person read the AI notes and continue, or will I have to have a handover as well? In the shift, what happens if information is not communicated between people in a handover? These are interesting areas where this AI causes huge amount of techno stress. So, for example, ChatGPT. This is an article published last year, April 2025. There are 1055 health related ChatGPTs, and they were used 3,60,000 times. 587 was psychology related, 247 in general medicine, 105 in oncology, 52 in cardio, 30 in immunology, 34 in other specialties. 624 including healthcare, doctors, nurses, psychiatrists, names or descriptions suggested they were taking on such roles. So, that means they were saying I am a doctor GPT, I am a nurse GPT, I am a psychiatrist GPT, I am an oncologist GPT, and they were marketed. But of these 624, none of them were FDA approved, because they did not come up as AI assisted device. So, there are numerous number of devices you can download as apps on your phone, and they are not regulated by anybody. So, that is a very important thing, indication creep. You may use it wrongly, and then there is no one to blame but yourself. So, this boundary between what you do and what that does is very important. Change management, I have talked about this. If the mode changes between version 1 and version 2, we may not know. If there are some small changes in the devices, we may not know what to do. So, especially when the mode changes, the model changes, and the old model does not work, it is a huge pain. We all know it. When you buy an Apple system, you are used on Windows, half the software do not work on Apple anymore. So, then that is a huge tension for people who are either way. So, this is the guidance document I told you about, FDA draft guidance document, AI enabled software 7-point guidance, and this is the practical guide, and it asks 7 questions. Who are the users of the AI? Second, you must design for trust, comprehension and safe use. So, trust is the most important thing. You should be able to trust the AI. Where is it going to integrate in the workflow? You know, sometimes these workflows are quite complicated in a large, huge hospital. We have so many campuses, Chittoor, Bagayam, Ranipet, Rusa, some Conch, some rural areas. How do you integrate this AI into that workflow? Training. How do we give training for doctors in 5 campuses? So, you know, don't just say it's very good, just use it. A backup, offline path. So, this is just a joke. This is the regular path. This is an example of online path, offline path, and this is the degraded path I told you about. It's the same path, but it's just slightly varied now. You will still reach there. The offline path is like if the system crashes, what are you going to do then? That's an offline path. So, you can have an online path, offline path to keep in your computer in case the AI crashes, and the degraded path is like a faded map. You can reach there, but you reach slowly. 6th part is evaluate, monitor and act. So, we must act on this AI, and finally communicate changes. So, just to say that this is the same thing which I went through, the biases in human beings, the 7 areas that we must act on, and if you have guidelines, which of these areas the guidelines talk about. So, this is also called sorry about that, international usability and engineering risk and management. It's a big huge word, but just to say that we have identified many areas where AI and healthcare can cause a problem. These are the areas in which we are making guidelines, and each of those guidelines, how do we engineer to make the biases less. So, that's just a mouthful of that. So, next time we take this AI, maybe a month from now, we talk about vendor disclosure framework. So, if Namrata has made an AI app and she comes to Georgie and says, your hospital must use my app, how do they have a conversation? So, this is a nice guidance document for that, HAIP, promoting AI vendor transparency in healthcare. There is a framework for that. We will talk about it next time. The last 1 minute is the future. There is a future AI consensus document, and obviously everybody likes the word future. So, just like remember this mnemonic, like we say FAIR principles for data sharing, like that there is a future principles for AI in healthcare. It should be fair. It should not, we can't afford AI in India and healthcare, only the rich countries can afford. That is not fair. Universal, everybody in the world, irrespective of your access, caste, color, creed, location, traceable. We should know how the AI came, where it went. Usable, everybody should be able to use it. Robust, it should be able to use in technologically challenged people who are tech savvy, with computers with low bandwidth, high bandwidth, and explainable. The bad word in AI is called black box. Black box means nobody knows what the AI did, but AI did something. So, it should be explainable. So, just to remember that very often what, like Dr. Vignesh did, we designed sepsis AI, then we developed it using data which he collected. Now, we are evaluating whether this AI is in a prospective study, the AI tool is useful. Lastly, we will deploy it in the hospital. So, there are different phases, and these are the different areas I talked about: fairness, universality, traceability, usability, robustness, explainability, and some general things. Government of India actually has guidelines for application of AI in biomedical research and healthcare, not only research, and this is a document which has been there from 2023, if anybody is interested in reading. Okay, bit of a wordy presentation today, apologies for that, but that was part 7 of our AI in health.